My name's Dr. Adam Weldon, and I'm a hospital consultant involved in the care of patients who present to the acute medical on-call. Thank you very much for joining us this evening. This is the second of a series of live free webinars, which is organised by the team here at UKGIM. It's clear that patient demographics are changing, with more patients presenting to the medical take with multiple comorbidities, and yet training opportunities have become increasingly focused and actually often really quite expensive. Our goal here at UKGIM is to provide high quality but also inexpensive training for doctors and for allied health professionals involved in the care of general medical patients. As part of our way of doing this, we're going to be offering a series of free webinars aimed at providing training for common presentations to the medical on-call. And we'd be really very keen to hear from you if you have any suggestions for topics to help meet any of your learning needs. Next year, we plan to host a conference called UK General Internal Medicine Conference. And we're currently developing this into a virtual platform in case the face-to-face conference is not possible. This is due to take place on the 2nd and 3rd of March 2021. For this, we've already recruited a really fantastic group of speakers from all areas across general internal medicine, and they're all experts in their field. The UKGIM conference is going to run in multiple streams of lectures over 2 days, offering 12 points of CPD. What that means is that delegates can construct their own bespoke programme of CPD. So if this is something which you think might be of interest, please do have a look at our website. That's ukgim.com, and currently super early bird tickets are available. Moving on to this evening's webinar, which will last for approximately an hour, we have a presentation from our guest speaker, Dr. Banerjee. Dr. Banerjee is a respiratory physician based at Southampton General Hospital and works across both respiratory and general internal medicine. Dr. Banerjee subspecialises in thoracic cancers, TB, and also performs complex bronchoscopies. Dr. Banerjee is also a Royal College of Physicians examiner for PACES and has multiple educational and research interests. There's going to be the opportunity to ask questions during the presentation, or we'll save them for the end of the presentation via the chat function of Zoom. If you put your questions there throughout the presentation, what I'll aim to do as the chair is try and bring any themes together and ask any specific questions to Dr. Banerjee at the end. So without any further delay, I'll hand over now to our guest speaker, Dr. Banerjee. Good evening.
Good evening, thank you. Let me just get my bit of the screen up. So I'm going to start talking about COVID-19, and I've spent the first several weeks of the pandemic managing patients on one of our wards. And I'm going to talk a little bit about my experience, but also talk through some of the literature. Unfortunately, although there is a massive literature out there, very little of it is actual randomized controlled trials. There's very little concrete evidence from which to formulate any kind of proper guidance. So I'm going to try and guide you through a little bit of the kind of quagmire that it's become. So as we know, there are the common symptoms of COVID-19, which are fever, dry cough, and fatigue. And the fatigue can be really quite profound. And interestingly, of course, that's non-specific to any number of illnesses. And at the beginning, as we were reaching the end of the kind of usual virus season, it was difficult to tell whether patients were presenting with COVID or with RSV or any of the other metapneumoviruses that were around at the time. But as of course the pandemic sort of took hold, more and more cases were very clearly COVID. We recognise there are a number of more uncommon symptoms, some headache, the loss of taste and smell, which has been well described and discussed, and I'll talk about a little bit as well. Nasal congestion, a sore throat, some of them cough and don't cough up sputum, some of them cough up small amounts of sputum, some of them cough up a lot of sputum, so it can be very variable. Of course, the breathlessness, the pain in the joints and the muscles, chills, nausea, vomiting, a bit of diarrhea, it's affected nearly every system you can possibly imagine. We also recognise that some of the patients get very severe disease and they become very sleepy. And interestingly, we were doing our ward rounds first thing in the morning and half of them were quite difficult to rouse. Very confused, cyanosed, and actually very breathless. There are relatively more rare hemoptysis, but some have this persistent pain within the chest that wasn't clearly due to myocardial ischemia, wasn't clearly due to bronchospasm, but they developed this heavy pain within the chest. So I'm going to talk about some of the patterns of disease and some of the ones that I've seen and some of the ones that are, I think are interesting to talk about. From the respiratory point of view, you have a clear viral pneumonia. You can see the consolidation on the lower X-ray, and they present with either infiltrates or full-blown consolidation or features of an alveolitis, such that they become very breathless, high work of breathing, tachypneic, very hypoxic, and with oxygen levels that seem to shoot up and down, but certainly they have a big oxygen requirement. There's also a group which we've seen who present predominantly with cough, and they have this intractable cough and are breathless, wheezy, very tight chested, and with an airway predominant disease. And they actually present slightly differently to pneumonias. They don't get quite so hypoxic, but what they do get is a very severe airways disease that needs treating and is treated differently from the pneumonic presentations. In terms of the cardiovascular system, we recognize that some of the underlying comorbidities that increase the propensity to develop COVID, so hypertension, diabetes mellitus, will also have an impact on the cardiovascular system. But these patients develop a viral infection, they get the pneumonia, they get an inflammatory response that then has an impact on thrombosis. And we've seen patients present with very clear thrombosis throughout the pulmonary tree, throughout the arterial tree, in various places through the arteries. And that may be one of the presenting features. We also recognize that the inflammatory process may lead to dysrhythmias, and we've seen a lot of atrial fibrillation, but also described our ventricular tachydysrhythmias. That the impact of inflammation on plaques within the coronary arteries may lead to them presenting with an ACS. And this is one of the difficulties because with COVID-19, they get a chest heaviness that you end up doing loads of ECGs and very rarely do any of them change. So there are a few that get an acute coronary syndrome, not as many as you'd think, but they also get a chest heaviness that can be then difficult to diagnose. And of course, the default position is it acute coronary syndrome? And more often than not, it isn't. Early on, there were reports from China of a myocarditis, but again, well under 10% of cases. And although we've seen a couple, not many, and it's not a particularly big feature that we have seen. What we do see is a rise in the troponin level and a degree of acute cardiac injury. And whether that's due to direct infection, whether that's due to the systemic inflammatory response is difficult to be certain about, but is certainly one of the features that we do see. Throw into that mix are the cardiac effects of some of the drugs that have been used all over the world. And I think the world's fallen into one of two big categories. There's either the treat with anything that might be vaguely helpful group, or the let's do this as part of trials group. And you can look at some of the countries around the world and it's very clear what category many of these have fallen into. But within those, you've got hydroxychloroquine and azithromycin, both of which have the potential to alter the QT interval and therefore to be arrhythmogenic. So in that circumstance, there is a vulnerability within the cardiovascular system in the context of COVID-19. there are neurological symptoms, and actually a lot of our patients wound up very dizzy. And it was really difficult to control the dizziness, and they found it difficult to get out of bed, difficult to sit up. Some had the headache, and they described it as a pressure on the head. But again, not a common symptom, but certainly one that we recognized. A number of them had, when you describe impaired consciousness, they were very, very sleepy, profoundly fatigued, and difficult. They spent nearly all day asleep. There are some reports, but again, case reports largely, of an inflammatory encephalitis or encephalopathy. Acute cerebrovascular disease is reported in about 1 to 2%, but not much more than that. Early on, of course, we had the peripheral nervous system features, and particularly impaired ability to taste, ability to smell, that we recognize and was included in the clinical definition of COVID-19. But also reported a vision impairments as well. But one of the other things that we recognize, and that I certainly recognize, is that a lot of these patients have a total body pain. So then I'm going to talk a little bit about the gastrointestinal system. And interestingly, the first patient I saw with COVID-19 actually had GI disease rather than classical pneumonia. It's described in about 15% of the patients with a bit of diarrhea, a bit of nausea, vomiting. They have a significant loss of appetite and very little abdominal pain. My patient had diarrhea and abdominal pain. If you look at the larger studies, loss of appetite and abdominal pain are both associated with more severe forms of the disease. So gastrointestinal disease, approximately 15% of the patients, the first patient I saw had predominantly GI disease. Diarrhea in a few, nausea, vomiting in a few, much more loss of appetite, a little bit of abdominal pain. It is recognized that loss of appetite and abdominal pain are more features of severe disease, diarrhea, nausea and vomiting less so. And that having GI features is associated with the more severe forms of COVID-19 in terms of pneumonia and respiratory disease, but is not associated with patients who necessarily are discharged or with mortality. The larger studies have shown liver injury with abnormal transaminases in about 19%, give or take. Now, the renal system, from the virus, a degree of hypovolemia occurs. And actually, one of the interesting things about COVID is that very early on, we were worried about filling them up with fluid, because when you have a viral pneumonia, alveolitis, lower airway and alveolar level disorder, you worry that with the capillary leakiness that occurs, whether filling them with an awful lot of fluid will lead to worsening pulmonary edema, worsening gas exchange and profound hypoxia. Now, what we noted, and I certainly saw a lot of, was that these patients became incredibly dehydrated. And that, of course, has an impact on renal perfusion, and as a consequence, their renal function would deteriorate. In addition, they have an inflammatory process, not necessarily through just cytokine storm, but actually through simply the inflammation that leads to a degree of endothelial dysfunction and therefore abnormal renal function. There is localization of the virus towards the proximal tubules, and you see in the post-mortem studies a degree of acute tubular necrosis. And so therefore you get further renal dysfunction. In addition to the endothelial damage, you have thrombi, which are a feature of COVID-19, and those thrombi and a bit of microembolism will lead to some renal infarction, and therefore again further impairment of renal function. So through all of these mechanisms, it's well recognized that you get an acute kidney injury as part of COVID-19. And I thought I'd talk about the dermatology. So there's this description of pseudo-chilblain on the hands and the feet, and you can see them on the pictures. Monomorphic vesicles, about 10%, urticarial lesions, about 20%, micropapules in nearly half the patients. And I must admit, I didn't spend a lot of time looking at the skin, but there is certainly descriptions of this. And an appearance of livido and necrosis as well in a smaller proportion. So I'm going to go and talk about the timeline of the symptoms. We recognize that from infection to the onset of symptoms was initially thought to be between 5 and maybe 10 days or so. And then you start to have the classical symptoms that we have already described. From that point, within about 7 days, medium time is about 7 days, you get breathlessness. And about 14% progress on to severe illness, 5% on to critical illness amongst the patient groups that we have seen. So they show up to hospital. The majority of patients, of course, will have relatively mild disease and will therefore be at home, and therefore we will not see them. But of the ones presenting to hospital, we recognize that the D dimer, being over 1,000, carries an increased risk of death. The CRP over 100, again, is a feature of severity. The ferritin over 500 micrograms per litre, again, features of severity. The creatine kinase rising, suggesting a degree of rhabdomyolysis, and whether this is a direct inflammatory event, whether it is a hypoperfusion event, whether this is a thrombus event, or whether this is direct viral myositis is difficult to be certain about. But given the sort of the severe myalgia that a number of these patients get, it is reasonably likely that actually it's a combination of all of the above. The LDH rising, the troponin rising without clear signs of coronary disease. So this is thought to be a direct viral effect on the myocardium. A fall in the lymphocytes, and again, an odds ratio of 4 for increased risk of death. Platelets falling, risk ratio of 8 for increased risk of death. And with the inflammatory process, a rise in the liver enzymes, rise in the prothrombin time as we described, and a fall in the renal function. So radiologically, now, very interestingly, the Chinese CT'd absolutely everyone at the beginning. And so most of the initial data on the radiology was all from CT scanning. Now, we took the view that CT scanning absolutely everybody was inappropriate in terms of radiation exposure and inappropriate really as an investigation. Plus, there's an issue with putting in potentially infectious people into a big scanner that's quite difficult to clean. So in terms of the chest X-ray, we recognize the bilateral infiltrates, which you can see arrowed on the X-ray. And it looks like someone's just simply taken a white crayon and gently, or white pencil actually, just gently shaded in chunks of the X-ray. As the disease becomes more severe, you see more extensive bilateral consolidation. Although unilateral consolidation is also recognized and unilateral infiltrates are also recognized, but a significant proportion, up to 63% of patients, depending on which study you read, may have a completely normal chest X-ray at presentation. So the radiology isn't by any stretch diagnostic. But what we also recognize, therefore, is that the radiology progresses. And this is within a few days from a relatively normal chest X-ray to impressive consolidation bilaterally. So this is from one of the early studies from China. And what it shows in terms of the progress of the disease is that with the symptomatology, so the top box is fever, orange, then cough, breathlessness, admission to ICU, systemic corticosteroid, and swab positivity. And what this shows is that between survivors of COVID-19 and non-survivors, those that, let me reshare this. Good. Sorry, this keeps logging me out for some reason. Is that one of the striking features is you could do the ward round in the morning and the patient looks relatively stable, is on 28% oxygen, isn't particularly febrile, maybe mildly tachypneic. And then by 2 o'clock in the afternoon, you're tubing them and feeling like an idiot. And what we recognize is that these patients change very quickly. Their oxygen requirements may rise very quickly indeed. They may go from being relatively stable to being tubed or even dead in a matter of hours. That apparent stability in the morning doesn't mean they're going to be stable at lunchtime, tea time, through the night, or the next day. And so we've needed to maintain much more close observation, I think, than we would of traditional viral pneumonias or even bacterial pneumonias, because of this very variable symptomatology, very variable rate of deterioration improvement. What we do know, yes, what we do know, however, and this is again from one of the original papers from China, is that if you look at survivors in blue versus non-survivors in red, this is the D-dimer. And if you plot the serial blood tests, you will see that non-survivors show a rise in the D-dimer. Non-survivors show a rise in the IL-6, which of course none of us can really measure. Rise in the troponin, and a rise in the ferritin, and a rise in the LDH. And we've used these to track, or at least suggest, that patients are going downhill. And this is against the ones that have survived, where you see that the lymphocyte count tends to stay relatively steady rather than fall, that the ferritin, the LDH, and the troponin remain either steady or tend to fall or stay within the normal range or thereabouts. So we've used the D-dimer, the troponin, the LDH, the ferritin as markers of deterioration. And we've got some study data to show that that's valid. There is, of course, descriptions and reports of the cytokine storm. And that's one of the other features that we have seen. And looking at this big cartoon, which of course I've borrowed, with the infection, you develop an inflammatory response with a delayed expression of interferon gamma, production of chemokines leading to the induction of very high levels of TNF, interferon alpha and beta, IL-6, IL-1 beta, and a whole soup of them. There's a whole kind of list of these. And what that leads to is essentially an ARDS type pattern within the lungs and a multi-organ dysfunction syndrome. To try and treat that or head that off, and this is in patients who are predominantly the ones who are in intensive care on a ventilator and may actually be on ECMO even, that we've tried a number of immune modulatory therapies in an attempt to try and modulate this. Now, many of them have shown some promise. None of the trials have been particularly big, apart from the dexamethasone trial, which I'll talk about in a few minutes. So there is the cytokine storm. Again, not very well described, but we recognize it as a phenomenon. It doesn't even have an official definition, but it's certainly a situation in which we see the patients deteriorate very suddenly. And the thought, of course, is that having never seen this before, so most of us have never seen coronaviruses before, don't have an immune response. You develop the infection, you develop a degree of immune suppression with a falling lymphocyte count, and then your immune system wakes up, sees it, and goes a bit mad. And that's kind of the pattern. And that's why you get some patients who seem to get better and then seem to get a lot worse. You know, the Boris effect, I suppose, if you want to use another term for it, where I'm okay, and then I'm sort of not okay. So I'm going to move on and talk about management of COVID-19. And I think the first thing to say is that we had them all isolated in wards and in bays, and they were terrified. And I think how terrified these patients were with a disease that the media were telling them they are going to die from it's impossible to underestimate. They were absolutely terrified. But they're also profoundly fatigued. They're in a lot of pain. Their musculature aches. And so we put them in bed and they rested as much as possible. They felt anxious, and there's a lot of talking to these patients in an attempt to try and make them more reassured. And certainly on my ward rounds, I would talk to them and spend the time talking to them on the wards and talking through their illness, talking through where they are, and talking through our expectations of where they would progress to. And I think that was a very important part of management. They were dry. They were incredibly dry. Anyone who knows me and has followed me on ward rounds would know I'm obsessed with looking at JVPs and hydration status, and these patients were very dry. And we filled them up with fluid and they did better. These patients lie in bed, don't want to move, are in a lot of pain, and therefore won't eat. So you can leave them a tray, you can leave them a jug of water, they won't drink it, they won't eat their lunches, they won't eat their dinners. They will become very malnourished very quickly. And so therefore, making sure they are fed, making sure someone takes the time to feed them, making sure that they are properly hydrated, even if it means we have an entire ward on intravenous fluid, was really important. They had a fever, leading to further loss of fluid and aches and pains, and making sure they had good analgesia to try and treat that, and in particular paracetamol, of course. And later on it was thought that we can use some non-steroidal, although with them, a lot of them having renal dysfunction and renal flow issues, you were rather reticent about giving them a load of non-steroidal, so predominantly paracetamol was important. There was the risk of venous thromboembolism, and very early on we recognized that those patients with a rising or a high D dimer will have, if you did a CT pulmonary angiogram, have pulmonary emboli, will develop deep venous thrombosis. And so therefore protocols have been developed for adequate venous thromboembolic prophylaxis. And depending on your unit, so I know that some in London went for higher dose thromboembolic prophylaxis, some went for rather more normal dosing of low molecular weight heparins, but getting that on board is really important. Gastric protection, a lot of these patients aren't eating and are sat in bed, and so therefore gastric protection important. There is some controversy about vitamin D, particularly it as an immune modulatory agent. And so what most of us have either taken vitamin D or supplemented vitamin D. There's very little evidence to suggest a benefit or a harm. And interestingly, I read a paper from Israel that said, oh yes, patients with COVID-19 are more likely to have a low vitamin D, but the difference between the two groups was 1 international unit. So not huge, but certainly statistically significant, depending on how you view that. So I think treatment with vitamin D absolutely can't hurt, may help. Treating pain and discomfort, central to what we did, absolutely central to what we did. And in getting them to then get up, get moving, get more mobile, and minimize the deconditioning that occurs when you are this fatigued, having maybe a bit of a myositis, lying in bed. And that deconditioning is important because it has a profound impact on recovery and on what happens after they leave hospital. Diabetes, I'm going to talk about in a minute. A lot of these patients had comorbidities, and we had to manage the comorbidities as they go along and make sure that the medications we were giving simply weren't interacting because they wound up on a lot of treatment. So diabetes management. Now, I was fortunate in that I shared a ward with our diabetes expert who basically fixed it for me. And it's useful to have that. But actually looking at the Diabetes UK website, who have really good both front door and in-hospital management guidance, the kind of summary is use a long-acting insulin, stop the glitazones, and watch very carefully for diabetic ketoacidosis. You've got very dehydrated patients without normal renal function, with an inflammatory process, and there is evidence that patients who had a propensity to develop diabetes would develop diabetes out from under COVID-19, but also those already with diabetes would get a lot worse. And one of the things we noticed was that patients on the ward with diabetes, their sugar started doing that, or just went up, stayed up, and wouldn't go down again. And so managing that became really tricky and involved quite intensive management of both the, looking for ketones, but also making sure that their sugars were under control. Respiratory management. And interestingly, we're going to talk about oxygen in a minute. Early on, there were studies that showed a degree of mucus plugging within the lungs. And we treated this mucus plugging with mucolytics. And it does work, and a lot of chest physiotherapy to try and get the stuff to move. And if you get the stuff to move, it will improve their oxygenation, so it was very important. Bronchodilators, particularly in those with the bronchitic airway disease type form, but actually with the mucus plugging, even in the pneumonic forms, bronchodilators were beneficial. Making sure that they were well hydrated, because if you're dehydrated, whatever mucus you have in your lower airways turns to concrete, and all the consistency of half-set araldite, and it's pretty thick and gloopy. They have cough, and quite a lot of my patients wound up on codeine phosphate linctus in order to try and manage this intractable, persistent, just wouldn't go away cough. They're coughing all the time. Now, the studies have shown that less than 10% developed a superimposed bacterial pneumonia. However, the risk is such that we tended to treat them with an antibiotic on the basis that if they did develop a bacterial pneumonia on top, that not treating that would be a bit of a catastrophe. Take a view as to whether treating something with an incidence of less than 10% is the right thing to do or not. And prone positioning. So if the patient could turn over prone, it improved their oxygenation. And again, reasonable trial data or study data to show that that was beneficial. And with oxygen management, of course, a lot of these patients would be confused and a bit delirious and wouldn't tolerate the nasal cannulae. And in some patients, we resorted to having someone with an open face mask or a nozzle of oxygen as near to them as you could get to improve their oxygenation as much as you could, simply because they would not keep the oxygen on. And so managing that oxygenation was very, very important. Of course, you've got the face masks, the reservoir masks, and we all know about improving oxygenation using oxygen. And aiming for target oxygen saturations that are between sort of 92 and 94%, not over-oxygenating in an inflammatory situation, but not under-oxygenating either. Nasal high flow oxygen, there's a lot of controversy about the use of it. It is an aerosol generating procedure and therefore carries risks of dissemination of the virus into the air. And so therefore needed to be done either in a hood or in an appropriate negative pressure facility such that staff would not be exposed to the virus in large amounts. And again, the same with CPAP. Now, these treatments should be used as a bridge to invasive ventilation. When we've tried them as an attempt to resurrect patients who we decided early on were not for invasive ventilation. In fact, the mortality was was well over 90% anyway. So therefore, you could take a view as to the utility of these treatments in patients who you are not going to actually invasively ventilate. So a lot of these patients some of these patients have abdominal pain, difficult to treat. I found actually giving them an antispasmodic like busarcan or bebevarin helped in some of them. With the dehydration, making sure they move their bowels. It's very easy to discover they haven't moved their bowels in 3, 4, 5, 6 days, and that carries a set of morbidities all of its own. Watching the renal function very carefully, watching out for the possibility of developing myocarditis. Early on, we were very worried about that. As time progressed, we were less so. With the chest tightness and the chest pain, making sure they've not developed an acute myocardial infarction in the context of being very inflamed and with their risks of thrombosis, but actually recognizing that that's relatively less common. The dramatic and sudden deterioration. You can see them 1 minute, they're going downhill and off to ICU whilst you're having your coffee after the ward round. It's that quick, and being aware of that. The rare development of secondary bacterial infection, again, the studies suggest less than 10%. And other infections that may coexist, difficult because there's very little data on that. Early on, making sure that you know who you're going to escalate to ICU and being clear about treatment escalation plans so that if they do dramatically deteriorate, that you're ready to deal with it. Hallucinations, a lot of them hallucinated, particularly the older patients, but they definitely hallucinated. And the treatment regime that kind of works, allegedly, is making sure their bowels move, making sure they're hydrated, orientating them. We tended to put them in rooms either by themselves or in little bays where nobody's talking and nobody's moving. And it's very easy to become very disorientated in an environment where you hardly see anybody. Making sure pain's controlled, the generalized aching. Sleep hygiene. When you're in a ward, everyone sort of sleeping, waking, it's very easy to lose your sleep pattern, and trying to make sure as much as possible that you can keep that under some sort of control is important. Mobilizing them as much as possible. It's very easy for them to leave them fatigued, aching, and lying in bed and not mobilizing at all. Making sure that they are fed. Again, as I said earlier on, they're not eating. Making sure they're well oxygenated. If they are hallucinating and their conscious levels deteriorated a little bit, a CT head, just to make sure that there are no signs of thrombus or basically thrombus, of clotting and of stroke. But again, very few of those were ever positive, and strokes about 1 to 2%. Making sure that their electrolytes are normal, making sure their bloods are maintained as normal as possible. And we've seen that in the inflammatory process, how abnormal the blood can become. Making sure that their environment, that it's as normal, whatever that means in a hospital ward, as possible. And family contact, and actually bringing in the iPads and getting these patients to talk to family was really important. But there are drugs that were suggested in patients who are very agitated, hallucinating and delirious. And there they are on the slide. So I'm going to talk a little bit about actual treatments. And I'm aware that Stephen Hawking said in his Brief History of Time that for every equation he put into his book, he'd lose half his audience. I'm always worried that for every study I put in, I'm going to lose half my audience, but let's give this a go. The Remdesivir study, 60 sites, 1,063 patients, published in the New England Journal of Medicine, 200 milligrams on day 1, 100 milligrams thereafter. Now they use this unvalidated, but clinically kind of how are they doing scale of status. Now, what's striking about this study is that 98% of the patients completed Remdesivir. The mean age was 58.9 years, which is interestingly lower than the average patient age in the United Kingdom. The median time from symptom onset to starting the Remdesivir was 9 days, so reasonably well into the illness. Now, this is a multi-center study. Interestingly, of the patients that they recruited, only 53% were white, of whom a quarter, give or take, were Hispanic. So not a very United Kingdom population. This is the kind of the patients that they had in the study. And what they had were score 7, which was ventilated were about a quarter, receiving non-invasive ventilation or high flow oxygen, about a fifth, and 40% on supplemental oxygen, and about 10–11% on no oxygen but in hospital. So a slightly skewed population, but the kind that we see in hospital nevertheless. And what they found, the recovery rate is really those that got better on their ordinal scale of good to bad. And they found that for those on ventilation, it made very little difference at all. For those on high flow oxygen or NIV, it crosses the midline, so therefore not statistically significant. For those receiving oxygen, they did feel better in that they recovered a little bit quicker. And it didn't matter when you gave it, less than 10 days or more than 10 days of symptoms, didn't matter whether you were male or female, and age range didn't really seem to matter. But what you saw was this is the proportion that recovered on these scales and days. And the Remdesivir group recovered a bit better and a bit quicker, largely on those not receiving oxygen or receiving oxygen, but for the high flow oxygen or NIV, and for the mechanical ventilation, actually very little difference. The mortality, not statistically significant, 7% versus 11% Remdesivir and non-Remdesivir. Side effects, anemia in 8%, acute kidney injury 7.5%, pyrexia, raising blood glucose, abnormal liver function tests, again under 5%. Last week, BMJ published a set of recommendations for the use of Remdesivir, and it's recommended for patients who are severe, with a respiratory rate of over 30 breaths a minute, respiratory distress, oxygen saturations under 94% on air, and requiring ICU admission, with relatively weak grade of evidence. The benefits are, for 1,000 people, 85 fewer deaths, low quality evidence, 19 more side effects that are serious, shorter duration of mechanical ventilation in 4 in 1,000, time to clinical improvement 3 days shorter, but no clear improvement in length of stay in hospital, because that's not necessarily related to recovery. There was a smaller study looking at the duration of Remdesivir that showed no difference between 5 and 10 days of treatment. But what's really interesting is that 86% of the patients completed 5 days, only 44% of the patients completed 10 days, and they excluded patients who were ventilated or on ECMO, so the more severe group were excluded. Dexamethasone. So this is a UK study. This is the recovery trial, and this is it as published in the New England Journal of Medicine. And the patients in the study, 54%, half roughly under 70 years of age, the remainder over 70 and 80. 2/3 male, roughly. And of the groups, 15% on invasive mechanical ventilation, 61% on oxygen only, a quarter not on oxygen. And 88% had positive COVID tests, 12% negative COVID tests, which kind of resembles what we see, which is about 80% sensitivity of the swab test. And what we saw was a reduction in mortality from 25 to 22%, 23%. And in terms of the secondary outcomes, in a reduction in invasive mechanical ventilation or death, and both invasive mechanical ventilation and death were reduced. So to look at the actual numbers at day 28, a reduction between usual care and dexamethasone of mortality, seen in ventilated patients, in oxygen treated patients, but not in those having no respiratory support. So what we're seeing is that the rate ratio for survival is much, much better for invasive mechanically ventilated patients, for oxygen only patients, but not for those not on oxygen. Convalescent plasma, tiny studies, N of 10, N of 20, really very small, suggestive of improvement, but by no means proven. And interestingly, the BMJ last week came out with a big table, which you can see there, of all the treatments that have been trialed so far. And in standard of care, they reckon that the standardized mortality is 33% amongst those who were in these studies. Mechanical ventilation, 11.6%. Adverse events on treatment, about 15%. And, sorry, just change the slide. Viral clearance, about 50%. Duration of hospital stay, circa 7 days. ICU length of stay, circa 10 days. Duration of ventilation, circa 10 days. Now, the glucocorticoids have an impact on mortality and mechanical ventilation. Hydroxychloroquine improves time to symptom resolution by on average about 4.5 days, but in reality has no impact on outcome. Remdesivir has an impact on time to symptom resolution, but no impact on survival at all. And that's the yellow, as you can see, no difference. Most beneficial, intermediate benefit, insufficient data. And the thing that's striking about this is it's mostly insufficient data. So finally, I'm going to talk about the one, it's a letter in JAMA that talks about follow-up of patients. So in their group, 143 patients, mean age 56 years, 37% were female, again, the same as most of the study groups. 70% had an interstitial pneumonia of some variety whilst they were in hospital. A 13.5 day length of hospital stay, 60%, they followed the patients up for 60 odd days. And at 60 days, 12.6% were free of COVID symptoms. 32% 1 or 2 symptoms, and over half had 3 or more symptoms. And what we see is that the fatigue, so this is what they had in hospital, and this is will last up to a month or more, a sicker syndrome, bit of rhinitis, red eyes, so continued symptoms for a prolonged period of time. And certainly patients we followed up all have the fatigue that seems to last 2, 3 or more months. And of course, those patients we do manage to get home. Many have had a venous thrombus of some variety, whether it's a pulmonary embolus or something else. I've seen 3 or 4 patients who towards the end of the first month of the disease have developed a reasonably rapidly progressive pulmonary fibrosis. Some of them were ventilated, some of them were not, but certainly features of an evolving fibrotic process that on CT looks like a non-specific interstitial pneumonitis or pneumonia. Some have developed cardiac failure as a consequence of the COVID-19 and need ongoing management of that. Some need ongoing management of the acute kidney injury or of their liver injury. There are emerging reports of degree of aspergillosis, but the really big features are the fatigue, the lethargy, and the deconditioning that continues. And I'm going to finish with a picture I really like by Edvard Munch, which is not something you associate with Munch, but I really like his paintings. Any questions? I've talked for a long time.
Thank you ever so much, Dr. Banerjee. That was an absolutely fantastic overview of a devastating illness, isn't it, with significant, profound inflammatory effects across all systems. There have been a lot of questions, and they really do range across the whole, well, all organ systems. But I'm going to start with something quite open, if I may.
Yeah.
And that's really to ask, given that it is such a devastating illness with, such profound inflammatory response and the possibility of some long-term chronic conditions, do you think that patients who are admitted to a hospital setting, particularly I'm thinking to perhaps the higher care areas, should be routinely followed up by
Absolutely.
specialists?
Absolutely. So what we've done as a respiratory team is we've actually developed a COVID follow-up clinic. Right. And patients who have been admitted to all of the critical care areas, the higher dependency areas, and anyone that the ward consultants feel have had a particularly stormy course, we are following up. Of course, the BTS recommends a chest X-ray at approximately 12 weeks to see whether the inflammatory process within the lungs is resolved completely and to see whether there are signs of fibrosis. What's very interesting is that on the post-mortem studies, 2/3 of the patients, and now clearly these were the worst ones, had a degree of pulmonary fibrosis on their lung pathology. And I've got a few patients who, when you drag them back to clinic and we're, seeing them face to face, you listen, still have ongoing pulmonary crackles and you worry, do they have pulmonary fibrosis? Some of those who have had pulmonary emboli and I have therefore done a CTPA at 3 months to see if the clots are resolving, have had evolving non-specific interstitial pneumonia on their CTs. And so therefore we are looking at them to see, do they have a progressive fibrotic process? Because if they do, that would suggest a abnormal repair response, which may continue to progress and therefore may require a treatment. And given that we have some antifibrotics, there may be a place for that. But again, it's all wide open because we simply don't know and we have no trial data to guide us. This is supposition and opinion.
Yes, and a lot of this research, of course, has happened in the last 2 months or so, really, hasn't it?
Absolutely.
In terms of, we all worry about a second wave coming, or perhaps this just becoming something which is ongoing over the next few years, something which doesn't go away. Are you aware of any risk stratification systems which might help people in terms of how we go about triaging patients? If we were to have a second wave, I know that was a focus of a lot of work, and it's a very difficult thing, isn't it? It's someone with multiple comorbidities. How far should we be escalating? Are you aware of anything around that?
So in terms of, we know what the risk factors are, but actually if you look at the risk factors for severe COVID, it's a list that goes off the end of a page. And it's largely those with the comorbidities that we recognize, the diabetes, the hypertension, respiratory disease, cardiac disease, and obesity. So those ones that you recognize are being more at risk. Sat on top of that, when they present to hospital, you have a group of patients some of whom are hypoxic, so therefore need to be admitted for oxygen support, but some of whom are not. And of those that I showed, so the ferritin, the LDH, the D-dimer, the troponin, and the CRP, those with higher numbers you would tend to want to admit because they are more at risk at the stage that they're at of deteriorating. But there are a number of patients who didn't have those features who we then sent home, who represented 3 or 4 days later with a crashing bilateral viral pneumonia. And so the problem at the moment is you do not know who's going to deteriorate and who isn't. And that's why what we did was we had a virtual ward. So you'd discharge them home, but you'd have people who would ring them on a alternate daily basis to see how they were and readmit them if needs be, and have a number of units send people home with pulse oximeters, which I think is a good idea because as your oxygenation starts to drop, that's the kind of herald that you need to come back in and be managed.
Yeah, thank you. There was a lot of work, really particularly at the start of the pandemic and sort of ongoing, around the relative risk of biologic medications and those who were having to shield or to self-isolate. I've heard some evidence from Italy and America that there's a thought process that actually the biologics may help dampen the immune response and actually be almost a protective medication. Are you aware of any work around that?
So the issue really is the is this weird biphasicness to the disease. So you have the initial infection, and of course, being on an immune suppressant makes you more likely, slightly, to contract it at the beginning. The problem is then that having contracted it, a proportion of people who we can't predict will then develop this secondary profound immunological response. And interestingly, we see not the same response, but a similar sort of immune reconstitution, immune going bananas phenomenon, both in tuberculosis that actually has an immune suppressive effect in its own right, and in some patients with HIV who you treat with antiretrovirals, where in the sort of early stage of disease, they may get a reconstitution or an immune response syndrome. And in those, so in those patients with COVID who then get that secondary big spike of immune response, as we showed with the cytokine storm syndrome, the immune suppressants like dexamethasone, like biologics, of course, would have a protective effect in that circumstance. So you, on the one hand, you're slightly more likely to get the infection because you've got no immune system, or you've got a suppressed immune system, but you're less likely then to get the severe complications therefrom because your immune system's suppressed. So it's a difficult one to balance.
Yeah, absolutely. Just one question on sort of follow-up and I guess trying to prognosticate in terms of disease progression and that sort of thing using imaging. There was a question around, is there a role for ultrasound of the lungs to see if someone's responding to treatment or not, or is it really X-ray and CT?
So the reality is that what you get is a bilateral consolidation. So your lungs become stiff and they become profoundly inflamed. And so when you then recover, what you find is that oxygenation improves, their blood tests improve. But of course, like with most pneumonias, the radiology lags behind and may not recover properly for up to a month, 6 weeks post-infection. And that's true of most pneumonias, so you don't do the follow-up radiology for some time afterwards. The reason really for doing follow-up x-rays, of course, is to see if they're developing the pulmonary fibrosis as the secondary consequence. The second issue, I suppose, is what is the role of stethoscope, ultrasound, some way of imaging or listening to the lungs? In the early stages of disease, what a stethoscope or something that looks at the lungs in that way will tell you is this a predominantly pneumonic or is this a predominantly airways disease? Because you'll hear the wheezing, you'll hear that side of it for the airways, or you'll hear the crackles if they have a sort of alveolitis pneumonia type pattern. It is said that ultrasound of the lung as a non-invasive means of detecting consolidation and its progression is effective, but again, it's very small numbers and it's largely an ICU, they're largely ICU-based patients who are on a ventilator. So the answer is there's not much evidence one way or another. The reality is, you know they're getting better when their blood tests get better, their oxygenation gets better, and they need less oxygen and they need less ventilation. And it almost doesn't matter what the pictures show, and it almost doesn't matter what they sound like, because they all sound terrible, and the pictures are always terrible.
Yes, thank you. And I'm just going to ask one last question before we wrap up, just in the interest of time. It's really around using the treatment of dexamethasone. Many of the patients, of course, that we will be treating with dexamethasone who are on oxygen in a hospital setting are going to have multiple other comorbidities and are going to be very prone, of course, to steroid psychosis and deliriums that come with that.
Yes.
Would it be your view, with the evidence we have, of course, that actually we just need to treat those other things if and when they happen? So I'm thinking if diabetes becomes a problem, if there is a steroid-induced psychosis, we just accept that that's a complication and then get on and treat? Or do you think we need to be quite specific in the people we choose to give the dexamethasone to?
Of course, in the ideal world, we'd be able to risk stratify the patients and work out who actually benefits and who actually doesn't. The trouble is we just don't have the data or the numbers to be able to do that. So at this stage, because so many patients deteriorate and you watch their lungs just fall apart and you watch them go onto a ventilator, not do very well and wind up permanently damaged. If you can reduce the number going onto a ventilator, the number deteriorating, absolutely I would crack on and treat with a steroid and deal with the complications afterwards, because the complications aren't anywhere near as bad as spending a month on a ventilator.
Okay, that's absolutely fantastic. Thank you. And I guess over the next few months, years, we're going to accumulate more evidence and things will get easier in terms of stratification, won't they?
Absolutely. One of the big problems that we have is that, so I did a simple literature search on COVID-19 and there are 3,500 PubMed hits. Yeah. At the moment, and that's just articles. Yeah. So there's a lot of, and actually there was an interesting article in, I think it was the BMJ recently, about how much bad literature there is out there. And it's because we've got a disease that we don't know very well, that we can't treat very well, we don't have a specific treatment for, and we don't really understand. And I think over the next few months, as the larger trials start to report and we're able to sit back and think, what really works, what really doesn't work, and how are we really going to approach this, that we'll have a clearer vision on how to treat it. And I'm hoping that that happens before we get to the point where we have a second surge. I noticed that the latest estimate was it'll be around December, so goodbye Christmas parties. But at this stage, I'm hoping that before we do get a second surge, and I have absolutely no doubt in my mind whatsoever that that's coming, that we will be in a better position to know what to do.
Thank you very much. It's a worrying time, but it's good to know there is significant research going on out there to help guide our practice. But thank you ever so much, Dr. Banerjee. That was an absolutely superb overview this evening of a very rapidly changing topic. So thank you ever so much. To the audience, I'm sure you'll all agree that Dr. Banerjee has given us a fantastic update and things which we can all use in our medical practice going forwards. I'd like to thank all the audience for attending the webinar this evening. It's been very well attended this evening. We're a small team here at UKGIM, but we are very keen to provide very high quality, either free or inexpensive CPD to medical professionals. If you've enjoyed this webinar, please do let your colleagues know about UKGIM or visit our website, which is ukgim.com. We're also on social media, so Facebook and Twitter. If you'd like to like us or follow us on Twitter, that's very helpful. If you've missed previous webinars, would like to watch this webinar again or share it with your colleague, it's going to be uploaded onto the UKGIM website and also onto Doctors.net, so there's a chance to catch up. I look forward to welcoming you to our next webinar, which is going to be on the 23rd of September with Dr. Chris Holroyd, who's a consultant rheumatologist. This will also be advertised on the UKGIM website at ukgim.com. So I'd like to wish you all a very pleasant evening, and thank you again to Dr. Banerjee for a fantastic presentation, and hope to see you all again soon. Good night.
Thanks very much.